What is a corneal ulcer? Most of you will define corneal ulcer as a discontinuity or a break in the epithelium of cornea. That's what you think is a corneal ulcer. But if you say this, I go back to my forensic days and I start thinking about the definition of something called as an abrasion. What is an abrasion, guys? An abrasion is a discontinuity in the epithelium. So if it is a discontinuity in the corneal epithelium, it becomes a corneal abrasion. That's all. It does not become a corneal ulcer. Then is abrasion equal or same as the ulcer? The absolute answer is no. So we have three words here, everybody. The first word is abrasion. The second word is keratitis. So abrasion is break in the epithelium. Keratitis is inflammation of the cornea. When you combine both, then it becomes a case of corneal ulcer. Okay, everybody? So you cannot just say inflammation of the cornea. You cannot just say discontinuity in the epithelium. You have to combine both to give me the definition of corneal ulcer. So let's see how to define a corneal ulcer, everybody. Discontinuity in the corneal epithelium with cellular infiltration and necrosis of the underlying layers. Okay? That is basically the stroma. The stroma is getting inflamed and infiltrated. Yes or no, guys? Am I clear about this? So corneal ulcer is nothing, if you imagine, but just a wound. Chot lag gayi. Yes or no, everybody? That's called corneal ulcer. Now, when we are talking about corneal ulcer, we are talking about some microbes, everybody, which can lead to the infection. So it can either be a bacterial ulcer, a fungal ulcer, a viral ulcer, and such. So we will discuss them one by one. We start first of all with, everybody, bacterial corneal ulcer, or I will just simply say bacterial keratitis. Even though the words are different, but they are used interchangeably. Now, I will begin with simple etiological questions, everybody. What is the most common cause of bacterial corneal ulcer or keratitis in the whole wide world? The answer is your favorite bacteria, guys, Staphylococcus aureus. When in doubt, mark Staphylococcus aureus. Yes, that is the philosophy we follow in life. Most common cause in India. But in India, we can't follow this Staphylococcus aureus philosophy. The most common bacteria leading to ulcer in India is pneumococcus. So the family changes from Staphylococcus to Streptococcus, Streptococcus pneumoniae. Now, this pneumococcus characteristically leads to an appearance of the ulcer, which we say as ulcus serpens. Serpens means serpentine ulcer. So the ulcer basically starts from the center, then moves towards the periphery in a zigzag sliding movement, you can say. Okay, in a serpentine S kind of a shape. Then hypopyon ulcer is the other name for this. Hypopyon corneal ulcer. Pneumococcus always leads to the collection of pus in anterior chamber. That is why the ulcer gets the name hypopyon corneal ulcer. I will show you the image. If you don't know what is hypopyon, if you have never seen an image of hypopyon, this is the image which I would like to show you, everybody. Let's see the image here, everybody. You can see the cornea in the center, everybody. And in the periphery, you can see all this sclera conjunctiva, which has been congested. Now, if I focus on the cornea, behind the cornea, in front of the iris, between the iris and the cornea, I see this collection of pus. This is known as hypopyon. Am I absolutely clear about this? Then in the center, I see a corneal ulcer. From the center, it will move in a serpentine fashion and it will reach the periphery. So that is why it is called as ulcus serpens, and this is called as a hypopyon corneal ulcer. So this is an image characteristic for pneumococcus. Am I absolutely clear, everybody? Let's move back. Now, some further simple easy questions. What is the most common cause of bacterial corneal ulcer, I'm writing BCU, in contact lens wearers? Contact lens users have a propensity to get corneal complications, obviously, because contact lens is over the corneal surface. So if it is not entirely clean, if it is not entirely sterile, then it can lead to infection. But which bacteria, everybody? The bacteria is now your second favorite bacteria when it comes to gram-negative, that is Pseudomonas. Pseudomonas will cause a corneal ulcer, no specific clinical feature or in terms of shape or presentation, but it always presents with, in the whole body, you will see green colored discharge. So the same is true for my cornea also. Always with green colored discharge along with the corneal ulcer in contact lens users. A history of contact lens. Moving on, guys. Most common cause of bacterial corneal ulcer in patients with prior history of LASIK surgery. Now, the point here is LASIK surgery. LASIK surgery, again, if we refer back to our optics, everybody chapter, we will know that LASIK surgery is done for myopia, hypermetropia, or any other refractory error. The surgery is doing what, everybody? The surgery is ablating the cornea. That means in any of these refractive surgeries, we are manipulating the cornea. That means there is some kind of exogenous infection which can come into the cornea. So which bacteria is important here? The most common here, the answer is atypical mycobacteria. Okay? So the whole classification, everybody, atypical mycobacteria, you should know of Mycobacterium clinoi, kansai, sacrophyllum, whatever, right, guys? Okay? Now, similarly, everybody, there is a specific bacteria that we need to know of, nocardia. Nocardia causes a specific shape of ulcer, which we call as wreath-shaped ulcer, or the other name commonly used is known as pinhead ulcers. Okay? Let's see the image. What do we mean by a wreath shape, or what do we mean by a pinhead ulcer, everybody? What is this, everybody? This is called a wreath pattern. This is a specific arrangement of flowers. You may have seen such an arrangement of flowers being presented to martyrs during their last rites. Yes or no, everybody? The same kind of presentation we are able to see in the cornea. Yes. Now, in this, you will see that there is an arrangement of flowers. You will be able to see in the periphery. I hope, yes. See, everybody, I am marking with this. You will be able to see in this. You will be able to see all this, everybody. I can say this, everybody. All this in the periphery. And in the center, there is a relatively clearer area. Yes. So this is likened to a wreath. Now, if we don't understand wreath, then the other name used is pinhead ulcers. Why is it known as pinhead ulcers? If I just circle these small opacities that you see. So I can say peripherally there are a lot of small ulcers arranged. I will again rub so that you can see carefully, everybody. So that is why we either call it a wreath pattern ulcer or pinhead ulcers. I hope we are clear with this. Wreath pattern. Okay, everybody? No confusion about this? Done? Let's move back, everybody. Now, once we are doing the etiology, there is a very important question about bacterial corneal ulcer which gets asked often again and again. Bacteria which invade intact epithelium. Okay? What are we trying to say? We are trying to say that first of all an abrasion occurs, discontinuity in epithelium. Only after that my microbial agents are able to enter and cause the ulcer or the wound. Yes? But there are certain bacteria which don't need the abrasion, which can enter even an intact cornea and cause the ulcer. So they are more dangerous to us. That's all. So what are the names for this? That's all we want to know. The first important bacteria here is, everybody, Neisseria. Both the Neisserias, guys. Meningitidis as well as gonorrhea. Okay? And the second bacteria is Corynebacterium diphtheriae. Third important bacteria in this list, Listeria. Fourth, Shigella. And fifth, Haemophilus aegypticus. Please remember the names of these 5 important bacteria which are severe as far as the causative agents of a corneal bacterial ulcer are concerned. Am I absolutely clear about this? Done? Once we know about the small etiology, everybody, and the questions asked on it, let's move on to the pathogenesis. Pathogenesis of a bacterial corneal ulcer. Okay? So, stage 1. Initial stage. In the initial stage, when the bacterial corneal ulcer has started developing, what you will see? You will see a saucer-shaped ulcer. I hope you understand saucer, everybody. Kind of a dish or a bowl that we eat noodles or stuff in. Yes? So, a saucer-shaped ulcer with overhanging margins. In the starting initial stages of any wound, everybody, what do we see? We see a lot of influx of fluid, edema. So due to that edema, the margins will be overhanging along with the saucer-shaped ulcer. If I show you a photograph, everybody, see everybody, this is stage 1. Yes, what are we able to see? An ulcer with overhanging margins due to the edema. Now, the second stage, everybody. This is called the progressive stage. In the progressive stage, basically, all the clinical features are occurring, you can say. In the progressive stage, you will see infiltration of polymorphonucleosides. Am I clear to everybody? So all the inflammatory infiltration is occurring during this stage. Yes? Again, you can see it in the photograph, stage 2. You will see the inflammation is increasing. The inflammatory cells are going into the underlying tissue. Yes? When these inflammatory cells are going into the underlying tissue, they can cause what, everybody? They lead to 2 things. Hypopyon. Yes? It is progressive stage leaking inside. Or it can lead to keratouveitis. Along with the cornea, the inflammatory cells also affect my uveal tissue. So keratouveitis and obviously the characteristic hypopyon that we already know of. When I talk about hypopyon, we have already seen the photograph, collection of pus in the anterior chamber. Please remember, in cases of bacterial corneal ulcer, 2 words about the hypopyon. Number 1, the hypopyon is thin. So it is mobile. So I will say it is a very liquid-like pus. So what do I mean to say by mobile? Look at me, everybody. Let's say right now the hypopyon is in the inferior part. If I will turn my head like this, everybody, yes, the hypopyon will also move along with the movement of my head and it will now affect this part. If I turn my head like this, now the liquid will move and come in this part. I hope you understand what I'm trying to say. So along with the movement of the head, the fluid will keep on moving as if it is water. And secondly, if we culture this hypopyon, it is absolutely sterile. You will not be able to culture any organism from this. I know the cause is infective. I am not denying that. But the pus itself is not able to give you any culture results. We call it sterile pus. Am I clear to everybody? Done? Now, let's move on to the third stage. The third stage is called as the regressive stage. In this stage, you will see that the floor and edges of ulcer, they become smooth, and you may see some kind of vascularization in the cornea also. That means the healing has started to occur. Yes, that is why the vessels have come. They are carrying your healing properties. The base and the edges have started smoothening out. That means the whole ulcer has started to fill up. Stage 3. Let's see the image. Everybody, you will see that the inflammatory response is decreasing. Yes, and the ulcer base is becoming smoother. You will see more undulations in the progressive stage and a smoother with less undulations in the regressive stage. Am I clear? Then stage 4. Stage 4 is basically the stage of scar or cicatrization. When healing has occurred, it will leave a opacity behind, a scar behind because of the fibrous tissue, and that will lead to permanent visual loss of a certain degree. Okay? So, visual loss, which is permanent. I hope we are clear about this. Again, we can see it in the image. This is our stage 4 with some kind of permanent corneal opacity here. No confusion about this, everybody? So, initial stage, progressive stage, regressive stage, and scar stage. Done? No confusion? Now, based on this, we understand the clinical features and how it progresses. But what can be the complications of a bacterial corneal ulcer? Okay, number 1. Ectatic cicatrix. Just a fancy word, everybody. Ectasia. Ectasia means what, everybody? Thinning. Yes? What are we trying to say? That there was a corneal ulcer. Okay? Let's see. There was a corneal ulcer, due to which the cornea has become thin in this part. Yes, everybody? Now, inside the eye, there is what, everybody? Intraocular pressure. The intraocular pressure is pushing this part out. It may bulge initially, then because of the formation of the scar, it may come back. Whatever may occur. Am I clear to everybody? So there is an ectasia. It is forming a cicatrix. So we are calling it an ectatic cicatrix. As simple as that. I hope I am absolutely clear about this. Due to thinning, bulging of cornea. Okay? It may be temporary or permanent. I hope no confusion about this. Now, secondly, everybody, I use this word, anterior staphyloma. Now, what is the difference between an ectatic cicatrix or ectasia and anterior staphyloma? Staphyloma is also, if you remember the lecture on optics again, staphyloma is also bulging due to thinning. Yes? But it is bulging due to thinning along with incarceration of uveal tissue. So see what I am writing, everybody. Anterior staphyloma. Bulging of cornea due to thinning along with, I hope you understand the difference here, along with incarceration of iris tissue. Yes? That the cornea is bulging, but along with that, some of the iris tissue is coming along with it. So the iris is also getting bulged. So cornea and iris incarcerated together and bulged together, anterior staphyloma. Let's see a photograph. Very important photograph here, everybody. I like to show you. Let's see this photograph. Yes? What do we see in this photograph, everybody? We see that some of the tissue here has bulged out. It is appearing slightly bluish in color, brownish in color from behind because the iris tissue has also bulged along with it. One lobule, and then we see another lobulated appearance. Yes, that is what is characteristic of a staphyloma, lobulated appearance. Okay, there is a bulge of cornea with incarcerated iris. Some of the iris tissue is getting incarcerated in this part. Some of the iris is getting incarcerated in this part. So that is why you will see a lobular appearance, not a smooth bulge, everybody. Am I clear to everybody? So this is anterior staphyloma. Done? No confusion? Now, let's see everybody. Complication number 3. Descemetocele. From the name itself, it is very clear. Descemeto, something to do with Descemet's membrane. Everybody. This is my corneal ulcer. The epithelium is lost. The Bowman's is lost. The stroma is lost. Now, which layer is there, everybody? Descemet's. So, let's say this is my Descemet's membrane. The fundamental is the same. The fundamental of pressure, everybody. Now, from inside, IOP, everybody, intraocular pressure, is pushing this part of Descemet's membrane out. So this Descemet's membrane is not able to hold the pressure. So it herniates out. Am I clear to everybody? Herniates through the corneal ulcer. And that is why it's known as descemetocele. Done? Descemet's membrane herniates through the corneal ulcer. Am I clear to everybody? There is no bulging. It is just a herniation, small area. Understand the difference. So this will be like this. I'll just redraw it for you to make it clear. My ulcer was here. This is my Descemet's membrane. This just herniates like this, in this small part. You understand the difference between a bulge? Bulge will be of a larger area, all the layers. Here, none of the layers, all the other layers are damaged. Only the Descemet's membrane is herniating out. Descemetocele. No confusion about this? Clear? Let's see a photograph, everybody, about this. Everybody see this. In this area, everybody, what do we see? That due to the ulcer, the Descemet's membrane has herniated out. A small herniation seen. Descemetocele. I hope there is no confusion about this. Clear? Done? Now, after all this, everybody, what is going to occur? If my cornea is not able to withhold the pressure in an ectatic cicatrix or in an anterior staphyloma or in cases of a descemetocele even, what will occur? Perforation of cornea. So in untreated severe cases of corneal ulcer, this is what is going to occur, perforation of cornea. Perforation, as soon as perforation occurs, what will occur, everybody? First of all, use your common sense. Aqueous will leak out. Yes or no? Aqueous is responsible for intraocular pressure. That means your eye will undergo hypotony, decreased intraocular pressure. Secondly, everybody, again, if you want a diagrammatic representation, let me try and show it to you. This is my cornea. Behind my cornea, everybody, is my ciliary body and my iris. This is my iris. This is my ciliary body. Yes? So now, let's say there is a ulcer here. Yes? Due to that, there was a perforation. Now, due to this perforation, what is occurring, everybody? The pressure difference is sucking the iris out. So the iris will get sucked out like this. Am I clear? Due to the pressure, everything will get sucked out. Atmosphere pressure is sucking everything out. So I can say what is occurring here, everybody? Iris prolapse. Am I clear about this? Iris prolapse. Let's see the image. If you don't understand this in a diagrammatic representation, everybody, let's see this. There was an ulcer. The iris tissue has got sucked out and it has led to the prolapse of iris out of the eye. Iris prolapse. Am I crystal clear? Now, let's see another scenario. I'm first giving it a name, pseudocornea. Then I will try to explain it to you. Okay? Okay. Using this figure only. Let's say the perforation was very small. This much. So what occurred? The iris got sucked out. No. The iris, in the process of getting sucked out, got stuck into the surface of the cornea. It was not able to prolapse out. You understand the difference? The prolapse is able to occur only when the perforation is slightly large. If the perforation is small, if the hole is very small, the tissue cannot go out. It gets stuck within the cornea. So now the surface of the cornea that is visible is cornea, a little bit of iris tissue in the between, and then again cornea. So we say the perforation has been plugged and the corneal surface has been reformed, but it is not a true corneal surface. Yes, there is some part of cornea and some part of iris in it. That is why we call it pseudocornea. Am I clear to everybody? So, corneal surface formed due to plugging of perforation by iris tissue. This is what we call as pseudocornea. Am I absolutely clear? Let's see an image, everybody. Very easy image. This image. Okay. You may find it difficult, I don't know, but if you try to see, this is all the opacity. There was the ulcer. The iris tissue was trying to perforate. You will be able to see a little bit brown part. The iris tissue was trying to prolapse through the perforation, but was caught in the center, and that is why you will see an intact corneal surface. Pseudocornea. Done? No confusion about this? Everybody? Now. Lastly, everybody, due to perforation, if nothing is done to treat it, infection will go inside the eye and it will lead to endophthalmitis, or I can even say panophthalmitis. Okay? If nothing is done to treat the cornea, this is what is going to occur. Clear? That's all about my stages and complications, important ones, of bacterial corneal ulcer. I hope we are all clear with it. Now, once we know this much, everybody, what is left, everybody? Management of corneal ulcer. Management. Management should involve what? Bacterial corneal ulcer. So if there is an infection, you will give antibiotics. But the question comes, which antibiotics? Will you give broad spectrum antibiotics? The answer is no. That is where the management issue starts from. Okay? So, scrape the base of ulcer with 15 number blade. Send scrapings for grams staining and culture. Antibiotics only after report. So I will say number 1. You have to give antibiotics, obviously. Yes. But they have to be started only after you're getting confirmed reports of whether the bacteria is gram positive or gram negative, whether it is a cocci or a bacilli. Okay, everybody? Now you will say, sir, culture reports will come in 48 hours, 72 hours. But gram staining report comes in half an hour. You are at least sure of the group of bacteria you are trying to treat. Yes? So using your pharmacological knowledge, you will be able to start an antibiotic. Please remember this. Now, normal antibiotics that we get in terms of topical antibiotics, the eye drops, they are not concentrated enough to be able to help in our treatment of corneal ulcer. So we have to use fortified antibiotics. Fortified means the concentration has to be made much more. The usual fortified antibiotics that we use are fortified cefazolin 5% plus fortified tobramycin 1.3%. Okay, everybody? So you have to dilute them, you have to mix them. I'm not going to the procedure of how to fortify. You have to increase the concentration. That is the basic fundamental here. Yes? Done? No confusion? Now, secondly, everybody, apart from antibiotics, what is the other thing you have to give? You always have to prescribe atropine eye drops. Okay? As supportive therapy. To relieve ciliary spasm. Due to the almost always accompanying keratouveitis, there is ciliary spasm which is contributing to the pain. So you have to give atropine. Thirdly, everybody, please remember, steroids are contraindicated as they promote epithelial thinning. Okay, steroids are anti-inflammatory. They will promote epithelial thinning and they will decrease the healing process. We do not want to give steroids. Anyways, we have an ulcer. Anyways, our cornea is thin. If we are giving steroids, we are increasing the chances of perforation. Please remember. Okay? In cases of impending perforation, you have to give oral doxycycline. You can use soft bandage contact lens. BCL we popularly call them, bandage contact lens. They are removable. They are almost like plastic. Just put them and you can remove them after 2 to 3 days if you want them to. Okay? Or you can use cyanoacrylate glue to stop the impending perforation. That is our management of bacterial corneal ulcer, everybody. I hope you have been able to understand. Please don't use antibiotics over the counter. Done? No confusion? Now, once we are through with bacterial corneal ulcer, everybody, let's start with the other microbe, that is fungal corneal ulcer. Yes? So, my first question, what is the most common fungi associated with causation of keratitis or corneal ulcer? The answer, everybody, is Aspergillus. Okay? Now, Aspergillus is which type of fungi? Instead of the name, they may give the group filamentous fungi having septate hyphae. With septate hyphae. So you have to remember this also, the classification. So they are using a little bit of microbiology in ophthalmology, that's all. Yes? Now, please remember, in cases of fungal corneal ulcer, patient classically gives history of trauma with vegetative material. Now, if you try to convert it into a question, you may have seen if you have done MCQs previously, everybody. The MCQs come something like this. A 52-year-old farmer from Rajasthan gives history of injury with sugarcane 5 days back. Okay? As soon as I hear this, what do I understand? Farmer. Farmer means working with vegetative material. History of injury with sugarcane. Sugarcane means vegetative material. As soon as I hear something like this, farmer and vegetative material, I know it is bound to be a case of fungal corneal ulcer. Yes? Am I clear about this? Done? Now, very importantly, everybody, once we know about this, we should know that the signs in cases of fungal corneal ulcer are out of proportion to the symptoms. That means the patient will say, sir, I don't have a lot of pain. There will be minimal redness. There will be minimal irritation. But when you will examine, you will see a fulminant ulcer already being formed. So the patient is not coming due to the symptomatic problem. The patient is coming because he can see some kind of wound or ulcer being formed in the eye. Yes? So what are the signs, everybody? Let's focus on the signs. Number one, everybody. First of all, dry looking ulcer. This is something which you understand with, experience, whether the ulcer is dry looking or is it wet and glistening. Okay, this is not something which I can teach you theoretically, basically. Secondly, everybody, feathery margins of ulcer. Important diagnostic point which you can see, everybody. What do I mean to say? Let's say this is my ulcer. One ulcer can be like this, a completely circumscribed with smooth edges. Or I am saying the ulcer in cases of fungi is like this, with irregular margins which look like the feathers of a bird. Yes, feathery margins of ulcer. Third important sign, everybody. Satellite lesions. What do I mean by satellite, everybody? What is moon to earth? That is what is a satellite. Yes. So along with the main ulcer, you will see some small ulcers in the periphery. So we call them satellite lesions. As simple as that. Then, everybody, another important feature is Wesley immune ring. Okay. So what is Wesley immune ring, everybody? Ring of immunity, antigens from the wound, antibodies, they are colliding at one place and they are visible as a faint ring. Okay. So around the ulcer, you will be able to see a faint ring of antigen antibody complexes, and that is called as Wesley immune ring. Okay. Lastly, everybody, hypopyon. Hypopyon or pus in the anterior chamber, we have again seen a lot of photographs already. Yes, but how to differentiate a hypopyon of bacterial corneal ulcer from a hypopyon of a fungal corneal ulcer? I hope you remember the bacterial corneal ulcer hypopyon was mobile, but in this case, it is immobile. The pus is thick. So because of the thick pus, if you will move your head to the left or the right, the hypopyon will not move. It is almost stuck at the inferior portion of the cornea, immobile. And it is asterile. That means you will be able to culture the microorganism from the hypopyon sample. Am I clear to everybody? So two characteristic differences between bacterial hypopyon and fungal hypopyon, right? Now, you've seen that I have made a diagram here of the fungal corneal ulcer. If you've understood this, along with the clinical features, you will be able to see all the same things in the image that I'm going to show you next. Let's see this image, everybody. Yes. In this image, what are we able to see? First of all, everybody, you see the ulcer in the center. And you will be very easily able to see that it does not well circumscribe. It does not have any smooth margins. Yes. Feathery margins of the ulcer. No confusion about this. Then, if we focus, we are able to see this small satellite lesion also. So, I'm marking this as a satellite lesion. Okay, everybody? Then, if I again focus, everybody, I am able to see this faint ring of immunity. Am I clear to everybody again? So, this is my Wesley immune ring. No confusion here, everybody? Yes. The only thing which we are not able to see here in this photograph is a hypopyon. If a hypopyon was present, you would have seen pus here, everybody. Yes. So this would have been a hypopyon. So all the characteristic features of a fungal corneal ulcer, why am I showing them to you in an image? As soon as an image comes, you should be able to diagnose without any history, without anything, that it is a case of fungal corneal ulcer. Please remember along with that the history of trauma. It will make your job easier. Done? Now, once we've been able to diagnose it, everybody, let's treat it. So obviously to treat it, we will have to give antifungals. No brainer, everybody. Which antifungals to use? Natamycin. 5% eye drops. These are the drugs of choice, you can say, because they can be used in cases of filamentous fungi, which are the most common cause, that is Aspergillus and Fusarium. But in case you have a Candida infection, you can go to amphotericin B, 0.15% drops. Please remember, atropine is used as supportive therapy, just like in cases of bacterial corneal ulcer. And again, just like in bacterial corneal ulcer, due to the fundamental of perforation and the risk for it, steroids are contraindicated. Done, everybody? No confusion, I hope, everybody. That's all about our fungal corneal ulcer. After this, we'll move on to the third microbial agent, that is viral corneal ulcers. Continuing with corneal ulcer, everybody, bacterial, fungal, viral done. So now the new agent that can cause is acanthamoeba keratitis. Small topic in itself. Now, we have heard acanthamoeba ulcer, acanthamoeba keratitis various times, I hope, along with the word contact lens users. Yes? So that is the first point that we need to discuss here. What are the risk factors which lead to acanthamoeba keratitis? The most important risk factor is contact lens use. Okay? But this is where the dichotomy comes. I also told you in bacterial corneal ulcer that the most common cause of bacterial corneal ulcer in contact lens users is Pseudomonas. Then if such a question is asked, what should you answer? Acanthamoeba or Pseudomonas? See, that is where the difference is. If somebody is wearing contact lenses, then the person is more bound to get Pseudomonas ulcer. But if you are wearing contact lenses and you are not cleaning them properly, that means contact lens use with contaminated solution, the solution in which the contact lenses are kept, or if contact lens is washed with tap water. In such cases, the answer changes and it becomes acanthamoeba. Are you getting what I'm trying to say here, everybody? Done? Clear? Secondly, acanthamoeba keratitis can also be acquired if you are a fool. What do I mean to say by a fool? If you are wearing your contact lenses and you are going swimming. So any problem with water basically is leading to acanthamoeba keratitis. So sometimes we also call it swimming pool keratitis, though that name is not very commonly used. So just remember this, dirty water, acanthamoeba, along with contact lenses. Done, everybody? No confusion about this, I hope. Now, what are the clinical features? So please remember, it is opposite to fungi. It is opposite to fungi in the terms that in fungi, the signs were out of proportion to symptoms. But here, the symptoms are out of proportion to the signs. So the patient complains of severe pain. That is usually why the patient has come to you, because of severe pain. And now when you are looking at the signs, you will see that the signs are very less compared to the degree of pain that the patient is reporting you. So what are the signs? Number one, everybody. Pseudodendritic keratitis. Already explained to you in herpes simplex and herpes zoster, told to you in the differential of dendritic ulcer. Second important sign is known as radial keratoneuritis. Again, if you focus on the English, it is self-explanatory, everybody. Radial means 360 degree, keratosis means cornea, neuritis means inflammation of nerves. So inflammation of nerves throughout the cornea, that is leading to the severe pain. I hope you understand this. And then thirdly, you can say almost diagnostic or pathognomic is the formation of a ring-shaped abscess. Ring-shaped abscess. Everybody, very easily discernible on a photograph. You will be able to see in this image that I've shown you on the bottom of the screen that there is a ring-shaped ulcer with some kind of pus collection in it, which is called an abscess. So this is a ring abscess. I hope I'm clear about this. No confusion about this? Done? So these are the three diagnostic clinical features of a case of acanthamoeba keratitis. Now, once we have diagnosed the clinical features, we need to confirm the diagnosis. The diagnosis can be confirmed via Gram's staining. When you do Gram staining, what are you able to see? You are able to see these double-walled acanthamoeba cysts. Okay, everybody? Or if you want to culture, what is the culture media, everybody? That is the question which is asked in microbiology also. Please remember, non-nutrient agar enriched with E. coli. So that's your culture media. Done? Am I clear? So we have seen the clinical features. We have confirmed our diagnosis by staining and by culture. Now we need to do the treatment. So let's see what is our treatment. Number 1, drug of choice. Drug of choice is something called as PHMB 0.02%. What is PHMB, guys? This is polyhexamethylene biguanide. PHMB, polyhexamethylene biguanide. Okay, please just write the name. The another drug, second, that we can use is chlorhexidine 0.02%. Both these drugs have the same mechanism of action in the fact that they will inhibit membrane synthesis. But if you actually ask me clinically, none of these two drugs is commonly used. Clinically, what we commonly use is propamidine. Okay? Propamidine acts by another mechanism, that is inhibition of the DNA synthesis. Am I clear, everybody, about this? Yes? Even though the drug of choice is PHMB, PHMB is not available at all. Very, very, very rarely you are able to find PHMB. So clinically we end up using propamidine. This is the most commonly available, easily available and used drug for acanthamoeba. But nonetheless, if a question is asked theoretically, you have to go with PHMB 0.02% as the drug of choice. That's a small topic on acanthamoeba keratitis. With this, we finish the third topic of the cornea, that is corneal ulcer. Please remember, first of all, keratitis, abrasion and ulcer, the difference between the three words, and then different sets of microbes. Bacterial, all the images I've shown you. Fungal, the single important image. Herpes simplex virus, the important topic in which steroids are used or not used, what are the epithelial, endothelial, blah, 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 and acanthamoeba keratitis. Are we clear about this, guys? Done? So now let's start with viral keratitis. Third topic, bacterial done, fungal done, viral. In viral, obviously the main virus that we are trying to discuss here is the HSV, herpes simplex virus. Now, HSV will cause infections in the eye, but as a primary infection, it will usually affect the conjunctiva. So in the primary infection, we are expecting conjunctivitis to develop. Okay? When there is a recurrent episode, then keratitis develops. This is usually what occurs, not the rule. Yes? We are about to discuss here keratitis. Now, so what are the clinical features or the presentations in terms of keratitis when caused by herpes simplex virus? So number 1, we say epithelial lesions. Herpes simplex virus can affect any level of the cornea, epithelium, stroma, or endothelium. Yes? So we need to be able to differentiate between the different types of lesions based on the layer affected. So what I'm discussing here is epithelial lesions. Epithelial lesions can present in three forms. Let's see the photographs and understand from them. A. What do we see in this image? We see number one, fluorescein staining, that we already know, green colored staining. Throughout the cornea, we get a stippled appearance, a dot-like appearance scattered throughout the cornea. This presentation is known as superficial punctate. As I have mentioned previously in other lectures, punctate means dot-like. So that is the word we use for dot-like lesions, punctate. Superficial punctate keratitis. Okay, everybody, SPK. Now, if it progresses, it will turn into this characteristic lesion, second lesion. Can you name this characteristic lesion, everybody? I hope yes. This is called as dendritic ulcer. Yes, you must have heard of this name. If not, then please understand, it is a branching ulcer just like a dendrite. So it is branching in different directions. Okay? If you see it microscopically, you will be able to see small terminal buds. At the end of each branch, you will be able to see small elevations, very small elevations. You cannot make it out in this photograph. It has already been stained with fluorescein dye, so the dye is filling everything. Yes? But at the end, we see terminal buds. These are the locations where the virus is being carried, and that is why the ulcer is getting progressed. Dendritic ulcer. If dendritic ulcer will progress further, all these branches will join together and you will get a large ulcer which will look like a map of a country or a state. And that is why this third epithelial lesion gets the name geographic ulcer. I hope I'm clear here. You will be able to see if I draw the outline. This is the ulcer. So all the dendritic edges have joined each other and it has created a large ulcer for us. Am I clear to everybody? Looking like the map of something. Geographic ulcer. These are all three epithelial lesions in continuation with each other. SPK, then dendritic, then geographic. No confusion about this? Now, if you ask me what is the treatment of epithelial lesions, then I will ask you to apply common sense. It is a viral lesion. So obviously I will use antivirals. But the question comes, which antiviral? So obviously 3% acyclovir eye ointment. Okay? It has to be applied 5 times per day for around 10 to 14 days. This is the regimen which is usually followed. This is an epithelial lesion. So the fundamental of the bacterial and fungal corneal ulcer will be applied here. If it is an epithelial lesion, if I give steroids, it will lead to thinning, it will lead to perforation, it will lead to inability to heal. So again we say in all epithelial lesions, steroids are contraindicated. So please remember the steroid part and please remember acyclovir. I have not written oral. I have specifically written ointment. Am I clear to everybody? No confusion? Done? So in all the three, SPKs, dendritic ulcer and geographic ulcer, the treatment will remain the same. Now, a question comes. What is the differential diagnosis of a dendritic ulcer? That means which other lesions can resemble a dendritic ulcer? So, acanth amoeba, keratitis. It does not cause dendritic ulcer, it resembles like that. So differential diagnosis. Secondly, herpes zoster virus keratitis, HZV. Thirdly, everybody, tyrosinemia. Okay, everybody? Tyrosinemia can also give corneal lesions which resemble my case of dendritic ulcer, or the overuse of contact lens. These are some of the important differential diagnoses that you need to remember when you are examining a case of herpes simplex virus keratitis. Am I clear, everybody? Also remember about epithelial lesions, that all epithelial lesions are due to active viral replication. So we need to know the three lesions, the treatment, and what is the cause? The cause is active viral replication. Now we move on a little deeper into the cornea, guys. We move on to the stromal keratitis. Now epithelium is not getting affected. The layer of cornea getting affected by herpes simplex virus is the stroma. Okay? When stromal keratitis occurs, this is the usual first presentation that we get. What is this, everybody? This is the usual first presentation that we get. What is this, everybody? This is known as ISK, or I can call it immune stromal keratitis. Stromal keratitis usually does not occur primarily as a corneal complication of HSV. You will see that first of all, some epithelial keratitis must have occurred. It has resolved. And then after some time, the stromal complications or the stromal keratitis lesions have developed. By the name immune, you understand that they are developing after some time when there is antigen-antibody reaction. Yes? So we say this is due to type 3 hypersensitivity. Okay? And it is almost always occurring after epithelial keratitis. Now the image is here. You must be wondering, what are you able to see in the image? So the image, you will be able to see a central, now focus very carefully, everybody, a central small stromal haze. So we say we are able to see a central stromal haze. Am I clear to everybody? Immune stromal keratitis. What is the treatment of immune stromal keratitis now? Everybody. That is where the difference comes. Obviously, first of all, you will have to use 3% acyclovir eye ointment. It is also viral. But along with this, because now the epithelium is not affected, topical steroids are also used. Am I absolutely clear here? Yes. Epithelium is not damaged, so steroids cannot cause thinning, blah, blah, blah. So to control the inflammation, we are using steroids also here. Moving on, everybody. Second lesion in the stroma, necrotizing stromal keratitis. I hope the name is self-explanatory. This is a more severe form of stromal keratitis where necrosis occurs, destroying all the stroma and the underlying tissue. The treatment will remain the same. Okay, everybody? Acyclovir along with topical steroids. No confusion, I hope. Now, let's move deeper. From the stroma, now let's see what will happen when there is an endothelial lesion. So the endothelial lesion which occurs is known as disciform keratitis. Disciform keratitis. Disciform. From the name itself, it is very clear that you will see disc-shaped lesions affecting the endothelium. Okay? So disc-shaped areas of deep stromal / endothelial edema. See, only endothelium is not affected. Even a little bit of the adjoining deep stroma is also affected. Okay? But this does not get classified as a stromal lesion because the primary site is the endothelium. This gets classified as an endothelial lesion. Please remember, this is a type 4 hypersensitivity reaction to herpes simplex virus. Okay, everybody? Done? No confusion? So these are the 3 levels of the lesions. Obviously, the most important are epithelial lesions. Please remember the use of steroids can be done in everything except the epithelial lesions due to herpes simplex virus. Okay. After having said all this, everybody, I will put a double star and I will write what is the hallmark of HSV keratitis. If we remember the basic anatomy where we had discussed the layers, the nerve supply, we should remember corneal anesthesia. Corneal anesthesia is the hallmark, everybody. Yes, there is anesthesia. You touch the cornea, the patient will not be able to blink. Due to this, there occurs something known as metaherpetic keratitis, or also known as neurotrophic ulcer. Am I clear to everybody? Because the patient cannot feel anything. So even when the eye is open and something dust and everything is falling inside the eye, the patient is not able to feel anything. So neurotrophic, due to degeneration of the nerve, some ulcer is occurring in cases of herpes simplex virus. So if somebody asks you neurotrophic ulcer is due to, what will you say, everybody? Due to fifth cranial nerve palsy. I hope I am clear here. Yes, what is the nerve supply of the cornea? Fifth cranial nerve. Corneal anesthesia means fifth cranial nerve palsy. Yes, done. That's all about herpes simplex virus. Please remember all these images that I've shown you and simple points that I've explained to you to be able to solve all the questions on it. Now, moving on to the other virus, everybody. Herpes zoster, causing herpes zoster ophthalmicus, or what we popularly call as shingles. Okay, everybody? Now, what we need to know is herpes zoster ophthalmicus or shingles usually affects the dermatome supplied by ophthalmic branch of fifth cranial nerve. Am I clear to everybody? So all this area, everybody, this gets affected. Where what occurs, everybody? As you can see in the image, rash. Okay. Now, if the rash affects the tip of nose, as is getting affected in this image, tip of nose, then the chances of HZO are increased. And this phenomena is known as Hutchinson's sign. I hope there is no confusion, everybody here. Done. Am I absolutely clear here? There should be no confusion in this. Done? If the tip of the nose is affected, then you know that the eye will be affected. If not affected, then the chances of ophthalmicus occurring are a little low. Now, what are the presentations, everybody? Clinical features, let's see. Number 1, pseudo-dendritic ulcer. As we discussed in the differential diagnosis of dendritic ulcer, something like a dendritic ulcer can occur in HZV also. So what is pseudo, everybody? Again, it will be a branching pattern, but there are no terminal buds. That is why it is called as pseudo-dendritic ulcer. Okay, absolutely clear? Now, the second important lesion that occurs is known as nummular keratitis. This can occur in other viral infections also, but in herpes zoster virus, it is seen very commonly. Now, in this photograph, what you are able to see? You are able to see coin-shaped lesions. Yes? Are you able to see coin-shaped lesions? These coin-shaped lesions denote nummular keratitis. So, coin-shaped subepithelial lesions. nummular keratitis. Am I absolutely clear about this, everybody? No confusion? Then, what else can occur, everybody? Number 3, mucus plaque keratitis in chronic cases. Number 4, everybody, just like herpes simplex, stromal keratitis can occur. Number 5, everybody, it can even lead to cranial nerve palsies. Lot of cranial nerve neurological complications can occur. Cranial nerve palsies can occur. The most common nerve affected is the third cranial nerve. Then please remember that if they ask you what is the least common ocular sign caused by herpes zoster virus, then the answer will be sclerokeratitis. Okay, just remember this is a straight one-liner MCQ. If somebody wants to ask you, even though the era of those kind of MCQs is now probably over, guys. Okay, number 7. Another important sign is post-herpetic neuralgia. Post-herpetic neuralgia, that even after 1 month of resolution of HZO, pain persists. And this pain is usually worse at night. So you have to inform the patient about this, that even though your lesion is treated, but in this area the pain may persist, post-herpetic neuralgia. Now, what is the treatment, everybody? The treatment is simple. Tablet acyclovir, 800 mg, 5 times a day for 2 weeks. That is the treatment of herpes zoster ophthalmicus. Am I clear, everybody? No problem? Done?